Good afternoon, everyone. I'm Ilsa Connect, and I am the Deputy Director of Public Policy for the National Center for Victims of Crime. I want to welcome you to today's web seminar, Sexual Assault Nurse Examiners and Victim-Sensitive Evidence Collection. And I want to just go over a few housekeeping issues for those who are not familiar with the WebEx system. This slide is about the fact that our audio is streaming over your speakers. So if you're not hearing audio, you're not hearing me now anyway, but this is for people who need to either adjust their speakers or go ahead and call into the teleconference. If you have any technical issues during the webinar, including audio problems, please first check your speakers and then call WebEx support at 866-229-3239. When you logged in, you may have noticed a poll at the right side of your screen. This poll helps us measure how effective our trainings are, so we would appreciate it if everyone would take a minute to complete the poll. We'll leave it up for a few more minutes, and then we will close it right before our speakers start. And just a note that all the participants on the teleconference today are muted upon entry to the call. So you will not be able to ask a question verbally, but we do encourage you to ask a question using the question and answer tool in WebEx. And I want to show you what your screen will look like during the webinar. It'll be a full screen like this. To find the question and answer tool, locate the floating toolbar in the bottom right-hand corner of your screen. Click on the question mark icon on the toolbar, and that will open the question and answer panel. So if you type your question in the small box at the bottom and hit send, that'll send your questions to us. And your questions are only seen by the panelists, so it will not go to all participants. We'll do our best to answer all of your questions today at the end of the presentation. We have a pretty full presentation today, so if we don't get to your questions, we will definitely follow up with you by email. And before we get started, I wanted to talk for a few minutes about the National Center for Victims of Crime. Our mission is to forge a national commitment to help victims of crime rebuild their lives. And we do this through direct support to all victims of crime on our National Crime Victim Helpline, 1-800-FYI-CALL. On that line, victims can get information from advocates about victim compensation, safety planning, and their legal rights, among other support. We provide technical assistance to those who work with victims, and we work with Congress to secure rights and protections for victims of crime, including funding for victim services. This webinar is the second in a series of 8 webinars. Upcoming webinar topics will include working with victims in cold cases and post-conviction appeals and exonerations, and using DNA to solve missing persons and homicide cases. So stay tuned for announcements about those webinars. And we will also be holding a 2-day free training on May 13th and 14th in Indianapolis, Indiana. Information about that training will be posted on our website coming up in a few weeks. And this is the web address for our online DNA Resource Center website, and all of the information about future webinars, all of the training, the 2-day training, and other DNA-related materials can be found on this website. And this is my contact information. If you have any questions or you want to email me about the webinar today or any other DNA-related issues, feel free to contact me. Okay, it looks like people are still answering the poll. I'm going to start introducing our speakers while we leave the poll up for another minute, and then we'll close it in just a minute. We have 2 speakers today. We have Jacqui Callari Robinson. She is the statewide SANE Forensic Coordinator for the Wisconsin Coalition Against Sexual Assault. Her duties include acting as an advisor and presenting on a variety of forensic-related topics, including medical forensic examinations for adults and adolescents, pediatrics and intimate partner sexual assault, strangulation, drug and alcohol-facilitated sexual assault, and expert witness testimony. She also provides case consultation and technical assistance and develops training materials, resources, and publications. Jacqui has been a SANE-A for the past 15 years and is certified as a SANE-A by the International Association of Forensic Nurses. She continues to care for victims of sexual assault at the Milwaukee Sexual Assault Treatment Center. Kim Day has over 28 years experience as an emergency critical care nurse. She has been working as a sexual assault nurse examiner since 1988. She was previously the coordinator of a local community hospital forensic nurse examiner program and the countywide sexual assault response team. Kim is now the Safe Technical Assistance Coordinator for the International Association of Forensic Nurses, where she provides technical assistance around the National SAFE protocol. She also develops and maintains the SAFE-TA source website, which is www.safeta.org. She coordinates regional trainings for multidisciplinary teams who are working to create or enhance community protocols for sexual assault forensic exams, and is hosting a series of national protocol topic-based webinars. I think there's one coming up at the end of March, but she might be able to mention that for you. Kim is certified by the International Association of Forensic Nurses as a SANE-A and continues to see patients at her local community hospital SANE program. So now we're going to have to go ahead and close the poll. And I'm going to hand over control to Kim. Okay.
Thank you.
There you go.
Thank you, Ilsa. Jacqui and I would both like to thank you and the National Center for Victims of Crime for allowing us to bring this webinar to you today on the role of the sexual assault nurse examiner and DNA evidence collection. What we hope to accomplish here today during our time together is we would like to increase your understanding about the role of the SANE and the role that they play in the proper collection of forensic evidence and in providing a supportive and empowering response to survivors. We also would like to discuss how SANEs increase the probability of obtaining probative DNA evidence while minimizing trauma for survivors, and how the involvement of SANEs increase prosecution rates. Through the webinar, we hope that you will become familiar with the importance of the medical forensic exam for DNA collection in sexual assault and other crimes, and why having trained examiners is important to survivors and the criminal justice system. How we're going to do that. We're going to talk first about a little bit about roles and definitions. We're going to talk about the sexual assault response, and we're going to talk about sexual assault response teams and that approach. We're going to discuss evidence and the SANE's role in identification, collection, and preservation of evidence. We're going to discuss the medical forensic exam. We're going to define that for you so you know more about that, and also talk about important legal issues that impact sexual assault nurse examiners and how they can testify. This slide just talks a little bit about different terminology. There are some terms that are used in different places. Different healthcare providers doing the medical forensic care of victims in your area. Different states have different terms that they use. For instance, you saw on my name on one of the first slides that I had FNE after my name. That stands for Forensic Nurse Examiner, and that's in Maryland. The Board of Nursing uses that terminology to describe my role. The role of the sexual assault examiner may be performed by a nurse or a physician or a physician's assistant. But for this purposes of the webinar, you'll hear Jacqui and I referring to sexual assault nurse examiners and nurse examiners. Sexual assault nurse examiners are registered nurses who receive specialized education above and beyond their basic registered nursing education, and also fulfill clinical requirements to provide comprehensive care to sexual assault victims. We do the medical forensic exam, and we can provide testimony in court. It's important to remember that trained examiners are really important with children, traumatized patients, and any victim of sexual assault. One other thing that we wanted to kind of just point out is forensic nurses are helpful in sexual assault, but there's also other patient scenarios that they might be used in. They were trained to identify, document, and treat injuries, as well as in the collection of evidence. These things can occur as a result of many different kinds of assault, not just sexual assault. And if you want to think about it, there's other types of victims that you might want to consider involving nurse examiners in. These include these issues that are listed here. And some of the things that we can do is document the injuries, talk about mechanism of injury, and collect evidence on these types of victims. When we're talking about sexual assault nurse examiners and their training, there are two pieces to that training. One is the classroom portion, where we go and sit in a class and learn about the role and about special situations related to sexual violence and the physical impact of sexual violence. And then there's the clinical portion. There's also, different states have different clinical practice requirements. Some states require 40 hours, some states require more. But the minimum recommendation is 40 hours of classroom and 40 hours of clinical. Board certification through the International Association of Forensic Nurses is when a trained examiner who's met the classroom and clinical training criteria, as well as some other requirements, sits for a board certification test and passes that test. And you'll see that both Jacqui and I had that after our names. And that will be noted by SANE-A or SANE-P after the name of the nurse. The response to sexual assault is victim-centered in focus. The victim is the most critical focus in the process. If we don't deal with the victim's emotional and physical needs after a sexual assault, we've all failed in our roles. The professional research and literature supports that the response of a trained sexual assault nurse examiner will facilitate the victim's response to the criminal justice system, and in the end, they will cooperate and the outcome will be positive, both in criminal justice response and in the patient's viewpoint. Some of this research was done by Becky Campbell and Deborah Patterson from the University of Michigan. Evidence that's collected in sexual assault cases will assist in linking the victim to the suspect to the victim, and the victim or the suspect to the crime scene. There's different pieces to that. Law enforcement can collect evidence at the location of the crime, and the SANE or nurse examiner collects evidence most often from the victim and the suspect. It's important that we work together as a team to facilitate this process. Here's a listing of what the typical sexual assault response team members might look like. Your community team may look like this. There may be more or less members on your team. What is important is that each of us works together and that we know the roles and responsibilities of the other team members so that we can better assist each other and the victim. As we're going through this, we wanted to just point out a little bit about sexual assault. I'm sure that many of you on the call have been working in this field for a while, and we know that the most sexual assaults are not committed by strangers. About 66% of sexual assault involve offenders who are not strangers. So then the next question may come up: why is DNA important in these kind of cases? Well, DNA is used as a tool not only to identify a suspect, but to support the victim's statement, link a suspect to the victim, a victim to the scene of the crime, eliminate or exonerate a suspect, convict the guilty person, identify and link an unknown suspect, and serial crime. So there's lots of pieces to that. A little bit here, too, about the DNA that's collected in sexual assault cases. The victim profiles are not put into CODIS, so they're not used to distinguish, they're used to distinguish the DNA from the victim and the suspect, but they're not put into CODIS to be found, for the victim to be found for a crime. And no medical information about the patient is revealed from the kit processing. Those are important points to remember. Now we're going to talk a little bit about exactly what the medical forensic exam entails. We start by gathering information from the patient for the medical forensic history, which we call. different than the medical history, because there's pieces that we're going to talk about as we go along that are different from just a standard medical history that you get when you go to the doctor's office. A very detailed examination. We document biological and physical findings. We collect evidence from the patient, and then we follow up as necessary to document additional evidence or injury resolution. We also coordinate treatment of injuries, provide care for sexually transmitted illnesses that the patient could have been exposed to. We provide pregnancy prevention and provide instructions and referrals for follow-up medical care. For those of you that are familiar with the Violence Against Women Act, this exam that I just entailed to you is referred to as the forensic medical examination. We want to talk a little bit about that medical forensic history that I was just speaking about. This is an important piece in the evidence process because it guides the nurse and the approach that she has to the evidence gathering process. I also want to point out that the medical forensic history can be very difficult for patients and for victims, and I'll use that word kind of interchangeably here. As we see in the following slides when we go along here, we're going to talk about some pretty intrusive personal questions. And it's really critical here that the advocate be an integral part of this process to assist the victim through this and be there as a support, and as well as being aware of the questions that we ask and why we ask them. The first one isn't too difficult. We ask about the date and time of the assault. The reason we ask this question is because it's essential to know the period of time that has lapsed between the assault and the exam. Evidence collection is time sensitive. The faster that you can get your evidence collected, the better it is for the DNA analysis. Interpretation of both the physical exam and evidence analysis are affected by time. The next piece of the medical forensic history includes the patient's medical history and any recent consensual activities. The interpretation of physical findings can be affected by medical data related to menstrual period, recent anogenital injuries, surgeries, diagnostic procedures, any blood clotting history, or any other pertinent medical history can affect the outcome of the exam as well as the findings that we have during the exam. The sensitivity of DNA analysis makes it important to gather information about recent consensual intercourse and whether it was anal, vaginal, or oral, and information like whether or not a condom was used. Again, these kind of questions can be stressful to answer, and it's important that we understand why we ask these questions to be able to try and alleviate some of that stress. Even trace amounts of semen or other body fluids may be identified that is not associated with the crime. Once identified, it may need to be associated with a consensual partner and then used for elimination purposes to aid in interpreting the evidence. Some of the other things that we ask patients are, what about their post-assault activities? Have they bathed? Have they washed? Have they urinated? Have they removed or inserted a tampon, a sanitary pad, a diaphragm, rinsed their mouth out, gargled, brushed their teeth, ate or smoked, or changed their clothes? These are things that we all ask, and they're all related to, they can relate or affect DNA collection. We also ask questions like whether or not there was a memory loss. They don't remember what happened to them. They might have passed out. They might have been vomiting. Whether or not they have pain or injury. Whether or not they've had any bleeding. They all can affect not only their medical care and treatment, but also the outcome of the DNA collection. Forensic scientists want information about cross-transfer of evidence between patients, suspects, and crime scenes. The gender and number of suspects offers guidance as to the types and amounts of foreign materials that can be found on people's bodies when we do the exam. Suspect information gathered during the history is limited to what will guide the exam and the forensic evidence collection. It's important for the forensic scientist to have that information. Once again, the importance of communication between team members is really important here too, because there may be things that will link the patient to the crime scene or the suspect to the patient that you find out during the medical forensic history, and those need to be communicated to other SART team members. Also, the nature of the physical assault includes things like where did the assault happen? If it happened outside, inside, whether or not there might be mud, debris, other things to link, again, people to a scene, a specific area where a crime might have occurred. This is one of the difficult portions for the patient. We talk about what has happened to them during the assault. We need to know what areas were penetrated, what areas had any kind of non-genital acts, and any contact. We want to know where were their bodies touched. These can be difficult to answer. They can also make the person relive the sexual assault experience. The questions require specific and sometimes very detailed answers. They might be very difficult for the patient to answer. The examiner needs to tell the patient why they're asking these, and it's really important for the advocate to be right along with them to understand why we're asking these questions. Some important points to make here is that the patient is informed throughout the process about why you're collecting things and what you're going to do with them. They have a right at any point during the exam to decline the collection of any evidence. And that's really important to remember, so that you can explain to them thoroughly why you're doing something and what not having something done, what effect that could also have. That's really important. Alrighty, I think these are pretty self-explanatory actually on some of these slides. We do collect clothing. This can cause, it just never fails that somebody's always wearing their favorite jeans when they have to come in for an exam. And again, I want to go back to that point about having the ability to choose not to have a piece of clothing collected. The examiner can modify the exam at any time, and Jacqui will be discussing that a little bit more in detail. But one of the things we can do is if the person doesn't want to give all their clothing, we can swab the clothing for DNA materials, as well as documenting where we see differences in the fabric, or maybe see evidence of secretions on materials. We also have to know if there's any areas that are kissed or licked, and we swab those areas during the exam. We want to collect as much evidence as possible from the patient, guided by the consent of the patient as well as the medical forensic history and things that we find out during the exam. If a person has pain or we see something that they might not know is there, then we want to collect that during the exam. And we also need to understand why we're collecting the evidence, as well as what information that can give us. It's really important that the nurse examiner understand very basic principles about evidence, including it's important to understand how it's processed, how it's tested. We need to understand that although there is danger of contamination, it is still important to remember not to get overwhelmed with that, meaning the victim is still the center of the process. We wear gloves, we change gloves frequently, but we don't need to wear full hazmat gear when we're treating the patient. We need to apply basic forensic principles like changing gloves frequently, washing our hands before we start. But we need to remember that the approach to the patient should not be hands-off. We always have to remember that the patient is the center of this. Doing things like packaging up evidence, explaining why we're doing what we're doing is really important, and it kind of helps the patient to be able to understand the process of the exam. I just talked a little bit about modification of the exam and evidence collection. I know that Jacqui's talked about swabbing genes before and just trying to get evidence from clothing. We do follow protocols, and we do follow kind of and the nurses will understand this term, but an algorithm approach to the exam. But we also need to remember that every exam is unique and every patient is unique. And things like where we look for to collect swabs varies with each individual. Both the advocate and the nurse should be sensitive to the particular needs of every patient. Sometimes the SANE will need to look to the advocate for clues about needs that she might not be seeing because she's involved in the evidence collection process. And again, this is all about teamwork. Now, Jacqui's going to talk a little bit about the examination.
Hello. I wanted to start off by saying that the physical examination itself can take up to 4 hours. And this is really critical for the team approach, where the advocate and the nurse really work together to let the patient know what's going on step by step, and to allow the patient to know that at any point during this examination, if they want the nurse to stop, that we are willing to do that every victim has the right to stop the exam at any point. But the physical examination itself, we will be obtaining the vital signs. We're noting the date and the time of the exam. We're looking at the physical appearance, the general demeanor, the behavior, and the orientation of the patient. We're looking at the condition of the clothing on arrival, because we want to see if this clothing can be used for some more DNA evidence. We will be recording all of the findings, which will also include some of those non-observable indications, like if there's pain or tenderness on palpation. We will be obtaining foreign materials like grass, sand, stains, or moist or dried secretions. We will be looking at the patient and the patient's body with UV lighting and looking for fluorescence. And we will be noting everything on the body diagram. We will also be using a colposcope to help us to identify small microtrauma. The angiogenital exam itself, again, we will be taking a step-by-step or algorithmic look at the body, slowly, cautiously, and carefully. We will be looking at the external genitalia and perineum area for injury and foreign materials, specifically looking at the abdomen, the thighs, the perineum, labia minor, major, clitoral hood, surrounding area, periurethral tissue, urethral meatus, the hymen, the fossa navicularis, and the posterior fourchette. Again, using the colposcope to help us to view microscopic trauma, and also for photographic documentation. We will then be looking at the cervix for injury, for foreign materials. We, again, using the colposcope or any other light source magnifying device. And we also may use adjunct therapies such as toluidine blue or an anoscopy if there's rectal or anal report or injury. For male patients, we will be examining at the external genitalia and the perineum area for injury, for foreign materials, and for other findings, including we will also be looking at the abdomen, the buttocks, the thighs, the foreskin, the urethral meatus, the shaft, the scrotum, the perineum, the glands, and the testes. And we will be documenting whether or not the patient is circumcised. So our documentation of findings are both written and photographic. We have narrative, then we have our diagrams, and then we will take photographs with either our colposcope or with a camera. And this will vary jurisdictionally. As Kim said before, we will be collecting evidence on the body and items that come with the patient. Clothing is a great source of DNA. That DNA dries and lasts much longer than DNA that could be found on the body. But both Kim and I have found with many of the patients that we've worked with that they don't want to always give up their favorite jeans, never mind their shoes or their coat. So what we'll specifically ask is, could we swab from that area? Or, is there, or can we take your jeans? Or can we take your pants? Again, we put the power in the patient to make that decision, and working with advocates is so important for us, making a determination as to whether or not the patient really, if this is okay with the patient, informed consent. This part of the exam sometimes takes a long time in of itself. And sometimes in the cases in Milwaukee, I will let patients go home for this part of the procedure. So discharging them, giving them all the information that they need about medications, and then going back into the room and drying thoroughly, packaging thoroughly, labeling, and sealing the evidence can sometimes take up to an hour or two in itself. We are collecting evidence in separate bags. Each piece of clothing is collected separately. Each swab is collected separately, documented, sealed, initialed, and turned over. Chain of custody is also very important, and documentation of that chain of custody is very important. Here are some overriding legal issues that are very important to patients and victims. I, like Kim, will use that terminology interchangeably. Confidentiality, in my experience, privacy and confidentiality is a major issue for victims. So we want to be sure that that we are allowing patients to know that it's their decision as to whether or not law enforcement is involved in these cases, and that we will maintain their privacy at the Sexual Assault Treatment Center and as SANE nurses. What we need to know, what SANEs need to know is for every jurisdiction the laws may be different. For every state the laws may be different. So SANEs need to be aware of what the reporting laws are, what the local protocols are, what the local memorandums of understanding are, and that they maintain their confidentiality with their client. Again, this slide also pertains to reporting options for patients. The first and foremost thing that I want to say about this is that every victim has the right to a medical forensic exam. Whether or not they're cooperating with law enforcement or working with law enforcement is really irrelevant. There are many things that SANE do that has nothing to do with the jurisdiction, the criminal justice system. So I encourage all law enforcement and all advocacy to encourage clients to seek medical care after sexual assault. However, if the client wants the medical forensic exam and does not want law enforcement involved at that specific time, in many jurisdictions, evidence can be held until the patient decides that they do want to go ahead with the case. In Milwaukee, we will hold evidence in the hospital, but in many other jurisdictions, evidence can be held with law enforcement. But patients have the right to decide whether or not they want to go ahead with the investigation. At the time of the medical exam, patients need to know how do I pay for this forensic exam. In the state of Wisconsin, medical forensic exams are paid through Crime Victims Compensation and a SAFE fund. And also the SANE needs to be aware of the reporting requirements as a healthcare professional, and what the details of that are. SANEs also appear in court, and we testify to what the patient reports, what we saw, what we heard, what we collected, how we collected, and what the patient reported to us. The most important thing for SANEs are that we maintain our objectivity and our neutrality. We state what we heard, what we saw. this is what we believe. We believe that all of us working together, victim-centered, are components of that large puzzle working toward the promotion of healing for the victim. Each of us is a very important piece of that puzzle, and as partners as partners with similar goals, we need to work together to help each other in our approach and working together to help the victim to move on with their life. As SANE nurses, working with victim services is very important. It's very crucial to our work. Without victim services, victims don't know that they can come to the hospital and get the medical forensic care. So what victim services can help us with is to tell the victim to seek medical care promptly, not to take a shower, to bring any clothing that they were wearing with them to that exam site. And all of these things will maximize the DNA evidence being obtained from that patient. The other thing that I think is so important working together as a team is that it gives patients the opportunity to really understand the process, what happens next. And as SANE nurses, sometimes we become very focused on the medical forensic examination and the medical forensic care, which is so important. So the takeaways today are that communication is the key, that working together and having ongoing conversations about working together is what is going to allow patients and allow victims to have choices in their medical care and in their forensic care and in their moving on to their healing. The other point that we wanted to make today is that each exam is very unique and very different. I can tell you in my career that there's never been one exam that's been similar to another, and I'm never surprised by how complicated these exams may be. I just know that working together with advocacy and with law enforcement has made our job so much easier, and I hope it has impacted victims in a positive way.
Hi, thanks so much, you guys. We have gotten some questions and we have some time, so why don't we go ahead, unless you have sort of closing comments you want to give before we get to the questions, either one of you?
I think there's a reference slide after this that talks about where using the national protocol, and there's just some references to what we've been talking today. If you want to, there you go.
Yep, there it is.
And our contact information is also on there, so that I'm more than happy to answer questions if we don't get to them today. This is Kim again. If you have any further questions about the national protocol, the medical forensic exam, or anything that we talked about today, we're happy to answer them, both Jacqueline and myself.
Okay, why don't we start with a couple. Somebody had a question about the suspect exam. Could you talk a little bit about that? What is it? How does it work? What are you looking for, and what happens to that information? Does it go into a suspect file? Does that information then go to the law enforcement? Can you just talk through that a little bit?
Sure. Suspect examinations follow a similar approach to even the victim examination, and Jacqueline, jump in here at any time too. We start and we do a head-to-toe assessment and collection of evidence. Usually it may or may not be related to something that you've been told either to look for by a victim statement, or it can be just guided by a court-ordered
or law enforcement request.
Correct, but I was thinking of what a court order to be able to collect certain evidence, or law enforcement request. And we collect the evidence usually in a kit, it's similar to the victim kit. It does have different pieces to it. I know in our state it's a different kit than the victim kit. And we collect the evidence, document any injuries on the person or any abnormalities that we find on the physical exam, collect swabs, and package them up just like we do the victim kit, and give it to the law enforcement officer who takes it to the lab where it's processed. And the lab will take that kit and compare it with any DNA that they find in the victim kit.
Okay. Anything to add to that?
Jackie?
No, I think that was perfect.
Nope. Okay. Wow, we're getting a lot of questions are plowing in here. Let's see. Can you talk a bit quickly about evidence and what's your? I mean, you did talk about sort of the victims don't sometimes have favored genes they don't want to give back, but you can talk about what's the process? When do they usually get their evidence back, or is that or their items back? I should say. Is there a usual amount of time, or is it just varied?
I can tell you that in Wisconsin, our crime lab doesn't give evidence back.
No, I can tell you in Maryland they don't either.
Yeah, so
get them back.
and I give that information right off the bat. I will explain to patients that you're not going to get the evidence back. You're not going to get your genes back. So 9 times out of 10, I will collect evidence right on those jeans or right on those pants or those shoes. If there's blood on shoes, I will collect the blood off of the shoes and just be really careful about how I document that. But I know that it is not the policy of the Milwaukee or the Madison Crime Lab to give back evidence.
And that will vary, Ilsa, depending upon where you are. But I know that, like Jackie said, it's similar in Maryland. So you would need to make sure that you're aware of what your policy is in the crime lab so that you can tell the person right up front what's going to happen and that you can be honest about it.
Okay, great. Question, how do you collect evidence from a reluctant child?
That's an art form.
It is.
I could tell you for me, I just had a 9-year-old last week who was a small 9-year-old. And we spent a lot of time talking, sitting on the floor, talking about the exam in detail. And it just takes more time. I can tell you that, again, this is another instance where working together as a team is just so essential. It's crucial. And having an advocate hold the hand of the child or having the mom hold the hand of the child, putting the child on top of the mom, there's lots of techniques that I will use, really try anything. It is difficult, and like I said, it is an art form, but patience.
I also think that that you don't just start in the evidence collection process. You need to realize there's a period of time that you need to take, and it takes a long time with kids to get their trust and be able to establish that you're not going to hurt them. And I even let them help me. I show them the swabs, let them swab me, swab the teddy bear, and just get them involved in the process. I think that with some kids it takes a little bit longer, but with other ones it doesn't. You just have to I think we've pretty much emphasized during the whole presentation that every person is individual and that exams are very individualized, and it's the same with kids.
Okay. What has been the longest time DNA post-assault was found in a START exam?
I just posed that question. DNA from where? DNA from the body or DNA from clothing? 2 different questions.
I think I did a timing considerations for evidence collection webinar on the SAFE-TA site. There's a webinar that you can listen to on that. And Dr. Jack Ballantyne, some of his research, he's found DNA from cervical brushings up to 17 days. Mm-hmm. But again, those are related to how active the person is, lots of different So in general, it's not that long, but there have been instances. And as DNA processing becomes more refined, they're able to take smaller and smaller amounts of specimen and get profiles. So we also need to remember that when we're looking at evidence collection. And
again, the time will really vary based on whether or not you're talking about cervical os evidence versus evidence found on clothing.
Yeah, and I think
a lot
really,
longer.
Yeah, and I think really interesting, I see one of the questions was the crime lab recently asked that somebody swab facial bruises where the victim was punched. That's a great thing
source
to put up there because you can get DNA from skin cells, certainly. So that's why they're asking them to do that, is because they're getting cells from the perpetrator's hand when they're doing the swabbing. And I think that's a great, I have found in my own practice that most of the DNA that I get is from body, either lickings or kissings or those sort of things. And I think any kind of touching is, especially a punch where you definitely have skin cells that are slough off.
Absolutely.
Yeah, especially as you say, the technology and the testing is becoming more precise. Got a lot of questions here. What about exams on transsexual victims? Any special comments?
There's no difference.
Yeah, there isn't. There really isn't.
There's no difference.
You still have
the algorithmic way that we do an exam is exactly the same way, no matter what body parts there are or are not.
Okay, and actually there was a question about that algorithmic. Can you talk through that for a minute? It's probably really involved, but if you can explain that a little bit.
What I mean when I say algorithmic is step-by-step cookbook, head to toe exam. We start at the head, we're looking at the scalp, we're looking in the eyes, down in the conjunctiva, in and around the mouth, under the lips. It's just a step-by-step way of doing the exam every single time, always the same way. So it becomes second nature. And then when you walk into the room, you're on autopilot. You're looking and collecting very instinctually and the same way every time.
Okay, great. We have a debate among our SANE nurses as to what they will testify to. One hates and refuses to answer any questions that contain the phrase consistent with, as in, is the injury you observed consistent with blunt force trauma? What's your opinion?
You know what? I have to defer to the nurse and whatever those nurses are comfortable with. I think it's an evolution of practice, which means that probably in the first 5 years of your practice, you might be a little bit more reluctant to say things such as consistent with. However, in my practice today, I will document and testify to consistent with. Less documentation around consistent with. I think I'm more apt to do that while on the stand and being crossed. How about you, Kim?
Yeah, I have the same approach that you are. I certainly would never stand in and say somebody should or shouldn't say this when they're on the stand. They have to determine how they're going to testify in their own ethical mind as well as their own clinical mind based on their own training and experience.
Okay.
And thank you to Fred Jackson for saying it was a search warrant that I was looking for.
Yeah.
That's the wording. Thank you, Fred Jackson.
Warrant.
That was the wording I was looking for the suspect exam.
Just to clarify too, I got a question to me specifically about victims' DNA, and I think we just want to be really clear about this, about why victims need to give a sample and then what happens to it. So can you just walk through that again real quickly?
Sure. Sure. The victim needs to give a sample of their DNA because they need to compare it to the other DNA, if there is any other DNA that's found on the person, to eliminate them. They don't put the victim's DNA into CODIS. What
Yeah,
they do
or the
is
national DNA database, just in case people don't know what that is.
Sure, I'm sorry.
That's okay.
Combined index data, combined data DNA indexing system, CODIS.
Right.
They don't put the victim's DNA in there. What they do is they develop a profile, then they'll take any other profiles that they get off of evidence, and they'll compare them.
Right. Okay. This is not, it's obviously, as we said before, not used to, investigate victims for other crimes.
No, it is definitely not used to investigate.
Oh, gosh, no.
I know that it seems like, Kim, you're seeing some of the questions. Do you see any that there's so many of them. We have a question about HIPAA, which I know could take all day to answer. Do you want to talk about that?
But you know what, that's a good question, though. I like that question.
Yeah, it says, can a rape center advocate coming into an exam as part of the SANE protocol be considered a violation of HIPAA?
This, as a statewide coordinator, this is definitely something that I have come in contact with numerous times. Hospitals telling advocacy centers that it's a break in HIPAA if they call them when a rape victim comes in. And what I can tell you is that the most important part to really clarify that question is to have the members of those SART teams meet together, have the hospital administration, have the law enforcement agency, the SANE nurses, all working together to figure out what would be in the best interests of victims. No, it's not a breach in HIPAA, and we've talked about that, and we have multiple articles out there around it. Susan Chasson has an article out about HIPAA and EMTALA and confidentiality around SART and sexual assault. That would be a great resource for this question. But no, we believe that working collaboratively with advocacy is in the best interest of sexual assault victims' patients. And to get around that is to work with your SART.
And this is Kim. I also would echo exactly what Jacqui said and tell you that there is a webinar that you can listen to, an archived webinar on the SAFE-TA website on patient privacy, which was a really good presentation by Jessica Minlin from Victims' Rights Law Center and Susan Chasson. And I really encourage any questions that you have related to that. There's some handouts there on the SAFE-TA site under training.
Okay, I've had a couple questions about just sort of that whole process of whether or not to report. And so, for example, one woman says, law enforcement is told they must store evidence kits regardless of whether or not victim is willing to report. They get a case tracking number. We are not sure how this will work. Do other states do this? And I know, Jacqui, you have some experience with this, and Kim, maybe you can just talk a bit about what you know other states are doing. It's kind of a big question.
Sure. And yes, it's a national issue. What she's referring to is what we call compliance. It's a Violence Against Women Act compliance issue. And to certify that you are in compliance means that every victim within your state has the right to the collection of forensic evidence and the storage of that evidence in a timely manner to make a decision as to whether or not they want law enforcement involved. And yes, there are many states that are having issues with this question. I can tell you, for Wisconsin as an issue, each jurisdiction is doing it differently. In Milwaukee, we took care of this problem by saying, okay, the hospital will hold the evidence. We give the patient 90 days to make a decision about whether or not they want law enforcement involved. Advocacy and crisis workers are involved with that client to allow that client to know that they have the 90 days, but at any time in that 90 days, if they want to report, they can. In other jurisdictions in my state, law enforcement will hold those kits. So each jurisdiction is different, and I know each state is doing that differently. Maybe you can talk more about that, Kim?
Well, I do know there is a a TA provider for forensic compliance, which is the Ending Violence Against Women International site, and that is www.evaw.org. They have kind of compiled a whole bunch of tools for you to be able to use to implement this type of program in your state, and it varies. There are states that have victims that can anonymously have evidence collected, like for instance in my state where the patient will come in, have the full exam done as if they were reporting to police. We have them document the circumstances of the assault on a separate paper. We label everything without their name but with a number, and then our police agencies have agreed to take that. But that was something that we established as a procedure and protocol through our sexual assault response team. Again, we didn't tell them what they had to do. We came up with this as a team, as the approach that we would take, because we were directed by the federal government that all victims have to be able to have a right to this exam. So we came up with this as a team. I know there's other states that have the programs themselves storing the kits, and there's some that have outside agencies storing kits, like sending it to a facility that under chain of custody will store kits. There's a whole bunch of different models. No one will work for every single area. That's really important to emphasize. And if you are looking for resources on those, if you can't find the EVAW website, you're welcome to contact me and I will give you what I have, because I've got lots of different forms and just some overall guidance on that.
Yeah, I just made a note to send it out in the, we'll send an email out to all participants in a couple of days with the link to the recording and the notes that are on the website. So we'll go ahead and send that link in that email. We have a couple more minutes. Before I forget, I want to mention that we have the post-test going on, the poll that's up, and we also have an evaluation that will pop up right when you sign off. If you can make sure to fill out the evaluation, that would be really great for both our presenters and for us in terms of our grants and knowing how effective our presentations are. Just a quick one to follow up on that last question. Can law enforcement require the name and date of birth on kits, or is that out of compliance? Just to clarify.
Well, it actually probably is still in compliance because they're not requiring the victim to cooperate with law enforcement. And they may be using that method to be able to keep track of where kits are. It does not, the police officer is not talking to the victim is not required to cooperate in order to have the exam done. So I would think that that probably is still in compliance. And again, any particular questions you can direct towards your STOP grant administrator in your state or your SANE coordinator in your state, or send me the question and I'll get you the answer.
Okay, thank you. A question about the surveys. Do you think that patient outcome surveys demonstrate the efficacy of SANE providers? Are they appropriate? We have tried unsuccessfully to implement some kind of measurement. I guess there's just a question generally about measuring how effective your programs are.
You know, I think that
that's a tough one.
That is a really tough one, and I think that there's some programs are successful in doing this, like giving the survey to the patient before they leave. Some are doing follow-up phone calls. I don't think there is any one answer because every victim is different.
I'm sorry, Kim.
Yeah, I think everybody's experience is different, and some may not want to be contacted. That's another whole issue. I do have some sample surveys and some samples that other agencies have used if you want to contact me. But again, this is a very difficult question to answer.
Sorry, I'm getting to your contact. There's your contact information.
Yep, and we too have done surveys in Milwaukee and in Madison, and they're usually phone surveys and a Survey Monkey once, which was completely unsuccessful. Try in Milwaukee. So what I would say is that I too have some templates that you can use. If you're interested, you can contact me, but this is a tough one. Victim advocacy centers seem to have better luck at that. I know from the coalition, we seem to have better luck at getting victims working with victim advocacy centers to give feedback than our SANE programs here in Wisconsin.
I just want to just pull it all together in the end. We've talked a lot about communication being the key, and if either one of you can just mention what, the best way to do that. How is it? You can't obviously have those conversations in front of the patient. You're going to do those in another format. Is that at the SART meetings, or do you usually advocate setting up, weekly or monthly meetings with everybody at the table, or what's the best format?
I would say overall those SART meetings are really the best way to problem solve before and after problems occur, and they have been very successful here in the communities in Wisconsin that are having them regularly, and that they be very formatted, that they be very structured, that it's not an opportunity to kind of yell at each other, but an opportunity for you to really figure out what's in the best interest of victims. How do we work more collaboratively together in the best interest of victims? So in some of our communities that have gotten some specific funding around SART development, they've been very successful in problem solving before and after some difficult cases. Okay. You want to add to that, Kim?
No, I think that's really good, and I think it'll be individualized based on the community demographics and where you're living as to how often you need to meet. It may be that you need to meet every month, say for the first 4 or 5 years, and then as you kind of hone your skills and work together as a team, and you may find that you only need to meet quarterly after that, but you always need to keep those lines of communications open. That's really important. So if you aren't meeting every month, you have a mechanism in place through your team to be able to troubleshoot any difficulties that come up. Waiting and ignoring them doesn't make them better. Right.
And I think just an interesting point, and there'll be our last point, was that communities have been over the past years including somebody from their lab in their meetings, whether or not it's a weekly thing is another story, but at some point they're having communication with their labs so they can have that feedback loop about what's going on at the lab, and it just informs for both the victim and advocate, how are things going? Is it going to take, is it taking a year to process kits right now, or is it taking 6 months? And getting that information and getting that into your sort of little circle of folks in your SART team can be, I think, really helpful when it comes to DNA issues.
Yeah, that's a great point, Ilsa.
Absolutely, absolutely.
I know that that there's some programs out there in the United States that have developed a checklist that they put in with each kit that they actually get back to the program about. That's kind of like a quality assurance for them. And I know that at my own program we usually invite the crime lab, because we have a state crime lab that we send our kits to. We invite them once a year to come because they have a log that they keep, and they write problems down. And I want to know it. If I'm working in a program, I want to know if my program's in that log for problems.
Mm-hmm.
So yeah. I think that they're a really important piece of this that often is not on that list of SART team members. But they don't have to be there every time.
Right. So it's a good tip for everyone. Okay, well, we're out of time. I want to thank Kim and Jacqueline, of course, today for a great presentation and for answering so many questions. We will get unanswered questions out to you by email. We did record the presentation today, so that recording will be available on our website probably in a couple of days. You can check back for that, and the notes are also on the website. And then just you can check out our website for the future upcoming webinars and for all of our other DNA-related information. And I want to thank you for listening and hope to see you all back here soon.
Thank you all.
Thank you.